Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Welcome to Doc Discussions. This is Jason Edwards, and I'm here with Dr. Meera Rana and Dr. Nanette Wendel. Dr. Rana is a medical oncologist, which is a doctor that gives chemotherapy or targeted therapy or even immunotherapy, and Dr. Wendel is a breast surgeon in our breast clinic. Welcome.
Thank you.
Thank you.
And so we actually work together a lot, and commonly we interact mostly in our tumor board. Dr. Wendel, do you care to describe to the listeners about what tumor board is and what the function of it is?
Sure. Here at St. Luke's, we have a weekly conference. It's held every Monday morning, and it's strictly for breast. There are tumor boards for other cancers as well, but we discuss only breast cases. And it's a multidisciplinary board where people like you, radiation oncologist, Dr. Rana and her colleagues, medical oncologists, are there, surgeons, pathologists, radiologists, and we present cases. Challenging cases, run-of-the-mill cases, just so we can all collaborate and get the multidisciplinary plan together for the patients.
Yeah. And so we choose kind of, or we discuss what kind of surgery would be best. And obviously you lead that discussion, and some patients will need systemic therapy or radiation therapy. And so we try to have kind of a comprehensive plan the best we can at that point. If patients have like a very early stage breast cancer, they have a couple treatment options. And over the course of time, we've tried to de-escalate the surgery for these patients,
Right.
whether it's the breast or the lymph nodes. Do you care to discuss that a little bit?
Sure. I've been at this quite some time now. So when I first started, mastectomy was the only option, period. And it was a modified radical mastectomy, which means that all of the lymph nodes were removed as well as the breast. It didn't matter if the tumor was 5 millimeters or 5 centimeters. It was all the same. And Meera, Dr. Rana can speak to this. A lot of people got chemotherapy in those days. It was very deforming. Reconstruction was not really up and running or an option at that time. So what we've seen over the years is less and less deforming surgery. We are now performing mostly lumpectomies, where we call that breast conservation, and that is mostly for cosmetic reasons. And it's been a tremendous move forward. We've also started taking fewer and fewer lymph nodes. In the advent of sentinel lymph node biopsy back in the 1990s, actually, I'll taught myself. I was among the first to be doing that. And that really has been a game changer in terms of morbidity, lymphedema, and that sort of thing. And really has brought us forward. So it's been a great.
Yeah. We've been able to kind of keep roughly the same cure rates, but have kind of less side effects from the treatment.
That's right. And I think an important point of that is that the survival with somebody who has a lumpectomy, including radiation, versus a mastectomy is the same. And that most people don't understand that. And I think that's a really important point.
Yeah. We have at least 6 large randomized controlled trials performed in different decades and different places. So that would be very close to the truth, as an epistemologist would say. And so when we are initially talking about patients in tumor board, sometimes we'll order some tests to see if they're candidates for chemotherapy, either before or after the surgery. Dr. Rana, do you care to talk about those tests, like the Oncotype test?
Sure. Yeah. So the Oncotype test is a relatively newer test that's really helped determine who might benefit from chemotherapy. So especially in some of the early stages. So historically, we used to it was actually more of a guessing game based on their pathology and what we thought. And so with the Oncotype, it takes the guessing game out of it. So it's saying, what is your risk of recurrence distantly? And what is the benefit of chemo? So the nice thing is it really does a better job of telling us who needs it and who doesn't. Now, don't get me wrong, there are some gray zones that do come up here every now and then with intermediate intermediate scores, but for the most part has really helped us quite a bit. Other testing that we do outside of hormone-driven breast cancers is, every time Dr. Wendel is doing a surgery or even a biopsy that's being done by radiology, we're always testing for ER, PR, and HER2. And so some of our patients who might be HER2 positive or triple negative might actually benefit from chemotherapy prior to surgery.
Yeah, you bet. And the what is the purpose of giving the chemotherapy prior to surgery, or who benefits getting it prior to surgery versus after surgery?
So that actually depends on their markers. So patients who are triple negative tend to have more aggressive disease. So in theory, they will most likely need chemo either before or after. The benefit of giving these patients who are either triple negative or HER2 positive before surgery is that it might make it easier for Dr. Wendel to do surgery for one. So depending on how large their tumor is, if they have lymph node involvement, it might help minimize, needing an axillary lymph node dissection, which is huge for lowering the risk of lymphedema as well.
Yeah. And so if patients have larger tumors, it can help Dr. Wendel do the surgery. Is there a size requirement that you look at, Dr. Wendel, for patients to see if they're a candidate for lumpectomy versus mastectomy?
Yeah, it's not an absolute number. Obviously, breast size comes into it, and it's a lot of judgment. When we talk about different tests, one thing that has brought us forward is the MRI. I find it very beneficial to have an MRI on anybody who has a breast cancer, because sometimes the tumor is larger than meets the eye on ultrasound or mammogram, and that may push them from a lumpectomy to a mastectomy. So basically, I look at things, I look at the breast size. If I think that they're not going to have a good cosmetic result with a lumpectomy and it's going to be very deformed, then we have to discuss a mastectomy.
Yeah. And how important is the cosmetic outcome to the patient? And this is not
Extremely.
like a scientific thing, but you see patients and you understand how they think and mentally and emotionally.
Yep, absolutely. It's extremely important because this is a devastating time. They have breast cancer, and if you can preserve the breast and preserve the cosmetic outcome, it's incredibly important for their psychological state and overall, well-being.
Yeah, I think one thing is that I notice is, the mental and emotional state of a patient. It exists on a continuum of time, and they're not always going to feel kind of the same way about the cosmetic outcome in the midst of the battle, like right when they're diagnosed, versus how they feel 5 years later.
Right.
And I think a lot of times patients underestimate how important the cosmetic outcome will be for their whole lives. And so have you noticed this too, Dr. Rana?
Yeah, I have. I've actually had some patients really ask me, what do you recommend? And I always say, you want to plan for a better cosmetic result because it tends to make more of a difference than a lot of people realize, especially for women undergoing chemotherapy or losing your hair most of the times. And that really plays a big role in confidence. And on top of that, having to do a surgery, which also can significantly affect that. So we do have a lot of conversations about that.
Yeah, for sure. And, a couple of people who aren't here right now are Dr. John Holson and Dr. Scott Geiger are plastic surgeons. And a lot of times if patients do have to have a mastectomy, I think we're really, really fortunate to have two really good plastic surgeons here to help reconstruct the breast and give them an acceptable cosmetic outcome. How do you work with the plastic surgeons, Dr. Wendel?
We work very closely together. I will plug them any day of the week. I've been doing this for a very long time, seen a lot of plastic surgeons, and these two are hands down, I think, the best I've ever worked with.
Agreed.
Their cosmetic outcomes are exceptional. And we work very closely together. When I find somebody that is interested in reconstruction, we immediately contact them, get them in. You get the surgery scheduled, and it's pretty seamless. They, at least at the time of mastectomy, will have either a temporary implant called an expander or the permanent implant. So when you're waking up, you already have a breast mound. And that, again, is such a psychological, has a huge psychological impact. You've lost your breast, but you look down and there still appears to be something there.
Yeah. Yeah. I do think half the battle as you're going through the treatment is on the mental side, just how you're thinking about life, how you think about your body, yourself. And so I think having good plastic surgeons and good general surgeons, and having really good cosmetic outcomes is, really, really important, even though in the midst of the battle, you just want to cure the cancer. But in the long run, that becomes a really important issue. So when a patient has a genetic mutation, such as a BRCA mutation, how does that change, surgically for the patient? Does that move the needle for you, whether you would proceed?
Definitely. There are some mutations that are stronger than others, but definitely the BRCA, the CHEK2, the ATM. In those patients, again, depending a little bit about age and things like that, I would probably counsel more for mastectomy and also consideration for a double mastectomy, because there is risk with those mutations, and that risk will be for life. So, you really need to consider if you have a breast cancer in one of those genes to potentially do a double mastectomy.
And which kind of patients do we actually do those testings in? So we don't do like BRCA testing in every patient. But which ones will we be more prone to do that with?
Sure. Anybody with a family history, especially, first degree relatives. Other cancers come into play. Somebody with pancreatic cancer in the family or melanomas in the family, we would do genetic testing. Somebody with bilateral cancers on both sides, triple negative cancers will all get genetic testing. All men get genetic testing. So it's pretty broad. There is a movement to potentially test everyone. I think that's, again, judgment.
Yeah. What is it? Maybe less than 10% for sure of all breast cancers have a genetic mutation, right?
Right.
And BRCA, I would assume, is the most common. Is that what we see? Or
nah,
not
actually,
necessarily?
No. I think I see more of the CHEK2 and the ATMs, to be honest. Yeah.
Yeah. And so there's been also this emergence of new systemic therapies that we use. Can you talk about kind of the old ones for like the estrogen receptor positive patients, but then also our PARP inhibitors or HER2-directed therapies as well?
Sure. So for hormone-driven breast cancers, we usually incorporate something called endocrine therapy. And these are medications, usually in the form of pills, to lower estrogen levels one way or another. So whether it's the production or the binding at the receptor level. Newer therapies that we're now incorporating also include immunotherapy in the chemotherapy setting before surgery, but then PARP inhibitors have made a huge difference in terms of risk of recurrences for patients. So specifically for those who have BRCA mutations, so we tend to do it on the back end, meaning after surgery, after having had chemotherapy, to lower the risk of recurrence.
And then, God forbid somebody ends up having distant metastasis, which means the cancer gets into the bloodstream and spreads to another part of the body, most commonly the bone. I've noticed that you guys are using kind of some newer targeted therapies. Can you touch on that a little bit?
Yeah. So for hormone-driven breast cancers, there's a big role of CDK4/6 inhibitors. So that includes a group of 3 medications that I can think of off the top of my head, but we have been using it in stage 4 hormone-driven breast cancers and are actually moving it up earlier. So for patients who undergo chemo, then surgery, and have any residual disease and are at a high risk of recurrence, we will start patients on these in addition to hormone-lowering agents for about 2 to 3 years, depending on the medication.
Yeah. And then we've used a drug class called immunotherapy in a lot of different cancers, and it's been really helpful in that it improves outcomes, but doesn't typically cause a lot of severe side effects, although it can in rare scenarios. Is there a role for immunotherapy currently or in the future for patients with breast cancer?
Yeah, so right now we're using it mostly in triple negative disease. So anyone who has stage 4, which means cancer that's spread to any other organs, and it's triple negative, we will incorporate it depending on a testing that we do on the tumor. The other situation is for triple negative breast cancer early stage when we're doing it before surgery. So we're combining it with chemotherapy. And actually, most patients are tolerating the immunotherapy really well. It's really more so side effects of chemotherapy that we have to monitor more closely.
Are you noticing any challenges in medical oncology for patients with breast cancer?
I do. I think probably one of the biggest challenges I see aside of, I think with chemotherapy, people mostly go in with the expectation that this is not going to be great. My life is going to be difficult. I'm going to have a lot of side effects. And so it's more expected. What I tend to see, and I think that probably surprises most patients, is really the long-term effects of hormone-lowering agents. So, these medications have been around for a long time. They affect estrogen. And on top of everything that most of my patients have gone through, including surgery, plus or minus chemo, plus or minus radiation, to be on a medication that takes away a lot from them can be really difficult. So we're talking about side effects, including weight gain, hair thinning. You're talking about hot flashes, not feeling great, brain fog. So I have a lot of people that say I was able to work really well, think quickly, just do all these things very seamlessly, and now I'm having difficulty. So I think that that's probably one of the biggest battles that I see for a lot of my patients is really long-term effects of being on some of the medications that we prescribe.
Yeah, for sure. And Dr. Wendel, how about you? What kind of challenges do you see in your clinic?
I think the biggest challenge for myself and my patients are in terms of educating them as to the outcomes with both lumpectomy with radiation versus mastectomy. Very frequently, the patients will come in and just mastectomy. I want a double mastectomy, period. And it's not always the best option. I mean, it is an option, but it's not the best option. So my job, I feel, is to educate and let them know that we do have different options. They're all excellent options, and a different way of thinking. And I always feel that when I have left in the room and someone has come in saying, I really want double mastectomies for, again, a very small tumor, and they leave there saying, okay, I'm going to have the lumpectomy, that I've really done my job well.
Yeah. I mean, we all have our own life experience, and we've all kind of heard through whatever kind of media it is, or through movies or articles we've read, we have these biases. And it is, I do appreciate patients putting their trust in us, knowing that, you've kind of got your life experience, but we've all seen literally thousands of patients go through the entire gamut of breast cancer treatment. And in general, I think patients do give us their trust, and listen to what we have to say, and end up making good decisions, for themselves in the long run. And of course, none of us take that trust for granted. We appreciate it. And so just in closing, what would you tell somebody if they were just diagnosed with breast cancer? Do you have any good thoughts or good advice that you could kind of give them off the cuff, Dr. Rana?
Yeah, so I think probably my advice would be take in all the information, ask questions, and ask to have that information repeated. We see a lot of people going through this, day in and day out, and they're being bombarded with information. It's hard to soak in, but at the end of the day, you want to make the right decision for yourself. And then knowing that you've got a team that's going to help you along the way. Yeah,
for sure. I agree. When patients come in, they're oftentimes shell-shocked, especially, when Dr. Wendel's the one who typically gives them the news. And do you find that kind of after you say cancer, there's not a lot that's absorbed after that?
Actually, I'm very fortunate because most of them already know their diagnosis. The way the system works is they have their biopsy, and then the nurse navigator does call them. So they are aware already. So the initial shock is a little bit worn off. So that we can have some discussions. And, I encourage folks to record our consult. I have no problem with that. Take a lot of notes. Bring someone with you so that you have another set of ears, because it is a ton of information, very overwhelming for them. So, yeah, I think that, that's pretty cool.
I think the first 2 weeks after a diagnosis is kind of the toughest, just because you were kind of flying high and then all of a sudden the floor dropped out from under you, and it takes a little bit of time to reconcile that. And then typically the emotions calm down and the logic kind of kicks in. And so, just if you can survive the first couple of weeks and try to get accurate information, it typically gets better for sure.
I think too, once they've seen one of us, they at least have some sort of a plan. And that is very reassuring to a lot of people that this is not a death sentence. And, we're going to take care of you. You're going to be fine. It is going to be a long road. But at least once they feel like they have a plan in place, the anxiety is much less.
For sure. You kind of feel anchored, once you've talked to somebody who's done it 1,000 times and they seem at peace with it. Well, I want to not only thank you both for coming on today, but I want to thank you for all your work you do for our mutual patients. I very much respect you and appreciate you both.
Thank you.
Thank you. Likewise.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.